So I would like to, at the outset, thank Dr. N. Khanna for giving me an opportunity to speak on this topic of duplex ultrasound in the evaluation of arterial diseases. So the disadvantages of Doppler ultrasound over the other non-invasive techniques is that the invasive diagnostic evaluation is obviated. There are no ionizing radiation. Equipment cost and floor space is 1/6 to 1/8. There is very little manpower requirement. Hardly one person or two persons are required, but one person should be highly trained. And the results are instantaneous and no offline analysis. So when you look at the arterial Doppler, as a screening technique, we have used ankle brachial index. And if you have a normal ankle brachial index of 0.9, but on post exercises, it becomes less than 0.85, but a critical ankle brachial index is less than 0.60. Then it is consistent with the peripheral arterial disease and is an independent predictor of mortality. However, this is a non-imaging technique. So imaging is then needed to confirm the location and degree of the narrowing before revascularization, or if the diagnosis of this PAD is uncertain. So duplex scans helps to identify these pathological lesions like stenosis, thrombus, aneurysms, fistula, and collaterals. Thus, the duplex scanning provides a combination of anatomical and physiological information that other imaging or physiological testing modalities cannot offer. Now, how is it done? Typically, this vessel is viewed in short axis with a linear transducer of a frequency of 8 to 15 megahertz. And then after doing the short axis, we go to the long axis by rotating the transducer to 90 degrees. And then we add the color flow, and then we can track the artery. Now, this is the Doppler spectral waveform in a normal patient. It has got a classical triphasic pattern. So if you look at this triphasic flow, you can see that it is a non-turbulent flow. This flow is a non-turbulent flow when you look at this. And this non-turbulent flow is indicated by the fact that there is a clear space within the Doppler spectrum, and the flow is triphasic. So this is when you add the color, then you can see that the color fills the entire vessel, and you get a color flow, this triphasic pattern. And then this peak velocity in the proximal arteries of the lower limbs, like the iliac arteries or the common femoral artery or the SFA, is in the range up to a maximum of 150 centimeters per second. So when you diagnose arterial obstruction, that is, first of all, you have to understand that when there is a narrowing up to 45 to 50%, there is no alteration in the Doppler waveform. The Doppler spectrum remains narrow, normal velocity, and triphasic. The normal flow reversal can be observed at arterial bifurcations or major branching, and the spectral broadening can occur as an artifact if the sample volume size is too large, that is more than 2 millimeters. Now, this is an example of a high velocity and turbulent flow across the narrowing, and you can see that there is a complete loss of the clear space of the Doppler spectrum. So when you assess the Doppler for the peak flows, then you look at the normal peak velocity in the proximal limb arteries, It varies from this 40 to 90 centimeters per second. More than 2 times increase in the peak velocity or more than 120 centimeters per second is equivalent to 50 to 70% narrowing. More than 3 times increase in the peak velocity or more than, although is actually equal to 90% narrowing or approximately 180 to 200 centimeters per second. And more than 4 times increase in the peak velocity is equal to 95% narrowing, and which is generally more than 300 centimeters per second. So what are the characteristics of the Doppler patterns in arterial obstruction? When you put the sample volume just proximal to the high grade narrowing, then you get a low velocity, high resistance flow. We call it a pre-stenotic damping. At the site of the high grade narrowing, there will be a high velocity spectral broadening and aliasing, and distal to the arterial obstruction, there will be a post-stenotic flow damping, which is characterized by low velocity, reduced acceleration, and a low resistance flow. So you can see that you have on the top panel a mild flow damping. On the middle panel, you have a moderate flow damping, and on the lower panel, you have got a marked flow damping. So what is this minimal stenosis? The minimal stenosis is there is no significant change in the color flow pattern. There could be a minimal spectral broadening, but it may not be there. There is a 1 to 29% increase in the peak systolic velocity, and the velocity ratio is 1 to 1.5, and the waveform is normal triphasic. When you get a moderate occlusion, then there is a spectral broadening, as you can see in this trace, that there is a loss of the clear space inside the Doppler spectrum, and this is the spectral broadening. This velocity ratio is 1.5 to 2, but the reverse component could still be present. And this is to show it diagrammatically that there is a complete fill of the Doppler spectrum with the Doppler flow signals, and therefore you don't have any clear space. When you have severe occlusion, then there is a easily visible narrowing, there is a color aliasing, there is a loss of the reverse component, marked spectral broadening, and there is more than 100% increase in the peak systolic flow. When you have a velocity ratio, we call it VR, if it is 2.0 to 4.0, it is less than 75% narrowing. When it is 4.0 plus or more than that, it is more than 75% narrowing, and you get a monophasic waveform with post-stenotic turbulence as indicated. And when you have this, you have a monophasic flow. So you can see that there is a near total occlusion, and the flow is occurring through the collateral channels, and distal to the obstruction, you'll get a monophasic damped flow. Now, the other thing that you look at it, that you get a distal flow beyond the obstruction will be low resistant with a power stardust pattern, and this is due to the collateral flow. And when you again see this post-obstructive phenomena diagrammatically, you see that the systolic and diastolic velocities are very close to each other, and you are having a highly damped pattern. The collateral flow is a low velocity monophasic flow. There is a loss of the triphasic character. There is a TARDIS power appearance and low resistance, which is related to the degree of ischemia. This is an example of an infrarenal abdominal aortic block. As you can see very clearly that this is an infrarenal abdominal aortic block, but the flow is occurring into the common femoral artery, SFA, and the profunda artery via the collateral channels. And the flow is then occurring into the PTA also. And what you also get is a slanted appearance, that is a slow acceleration, with the acceleration time being more than 100 milliseconds as compared to the brisk acceleration that you get in non-critical blocks. And other finding could include a color aliasing, which is a focal narrowing, but sometimes due to the vibration of the soft tissue due to turbulence, you can get a color bruit. So when you look at the stenosis, this is an example of a pre-stenotic high resistant flow on the left, and on the right you get a high velocity flow with a velocity ratio of 7.0, indicating more than 90% narrowing. Now, this is a case study of a 66-year-old female patient with complaints of pain in the right leg after walking. And you can see that there is a normal flow in the left SFA. But when you look at the right SFA, you get a monophasic damp pattern, indicating that there is some problem proximal to the artery. And when you look at this popliteal artery, the right popliteal artery shows highly damped flow, while the left popliteal artery is normal. When you look at the anterior tibial artery, you get the same findings. So when you look at the actual site of the lesion that you do abdominal scanning, and you look at the right common iliac artery, you see a critical narrowing at the right common iliac artery with a high velocity flow of more than 4 meters per second, which indicates more than 95% narrowing. And you see a partial damping of flow in the distal right common iliac artery on the right side. Now, there are some applications of Doppler in graphs. You have this peroneal artery graph showing stenosis, and this graft is of the saphenous graft, and you see high velocities indicating that there is a narrowing at the site of this anastomosis with the peroneal artery. And when you do a revision of this anastomosis, then these peak velocities, they fall to 100 centimeters per second from an earlier one of 200 centimeters per second. Now, this is a pseudoaneurysm. This is due to a rent in the artery, which occurs generally due to iatrogenic procedures or could be due to trauma. And you can see that this is surrounded by clot. The wall of the pseudoaneurysm is surrounded by clots, and there is a small rent. And you can see you can get a classical to and fro pattern, the flow occurring from the rent into the pseudoaneurysm and from the pseudoaneurysm back into the artery. And this also shows you a narrow rent that is seen just at the mouth of the pseudoaneurysm. Now, this is to differentiate between a hematoma and a pseudoaneurysm. You can see that there is an excess graft, and in the process of placement of the excess graft, there was bleeding, but this is a hematoma. There is no flow into the hematoma, so this is not a pseudoaneurysm, and you can see the flow in the excess graft channel. You have a power Doppler mode, which is used when you have low flow states or when aliasing causes problems and you cannot view these background structures, and where optimal angles are not available. Then this is a non-angle dependent power Doppler, which you can see on the right-hand side, and you see that the quality of the image is better as compared to on the regular Doppler on the left-hand side.
Dr. Kapur, kindly conclude your slides.
Just give me another half a minute, please. Or you can say 10 seconds. The limitations of the Doppler ultrasound in the evaluation of vascular pathologies is that it is highly operator dependent. If you may not always have a good acoustic access, there is angle, because it's a Doppler technique, it is angle dependent, and there is non-visualized flows may not be always equivalent to absent flows. That is the first axiom in Doppler that we teach our students, that the non-visualized flows are not equal to absent flows in every case. And the other limitation is that the disease may be underestimated in the presence of a long, smooth plaque that does not have the accelerated turbulent flow patterns associated with hemodynamically significant lesions. high and low cardiac output can affect the peak systolic velocity. Therefore, in the setting of a markedly high or a markedly low cardiac output, the peak systolic velocity ratio should be the primary diagnostic criteria for diagnosing this obstruction. Thank you very much. Thank you.
Thank you, Dr. Kapur. We will have the discussion toward the end of the session. May I request my co-chair, Dr. Magesh Banur, to introduce Dr. John Christopher. There cannot be a cardiac imaging session and without John Christopher's participation.